very long presentation. Thank you very much, Professor Abdallah Shihab, for the kind introduction. Professor Giuseppe Rosano, Professor Peter Severovich, Professor Juwairia, Professor Harari, thank you very much for inviting me in this excellent meeting. So in a couple of minutes, my assignment is to cover the new devices and intervention for mitral, tricuspid, and aortic. This is my disclosure. We know that in patients with heart failure with reduced ejection fraction, secondary mitral regurgitation is common, and the mitral valve is a complex anatomical and functional unit because it consists of not only of the leaflets and the annulus, but also the subvalvular structures, the cord, the papillary muscle, ventricular wall. So ventricular annular disruption is responsible for secondary mitral regurgitation due to dilated left ventricle, due to tethering of the mitral valve leaflets, dysynchrony, decreased contractility, annular dilatation, high LV filling pressure, and high left atrial pressure. In heart failure with mild reduced ejection fraction and preserved ejection fraction, the atrial annular unit is responsible for functional mitral regurgitation due to dilated left atrium, due to annular dilatation, due to high LA and LV filling pressure, and decreased annular contraction. So this is a typical example for functional mitral regurgitation in ischemic heart disease due to tethering of mitral valve leaflets. And on the right, you can appreciate the degenerative mitral regurgitation due to leaflet prolapse with eccentric mitral regurgitation by transesophageal echo. So we have different therapeutic options for management of secondary mitral regurgitation. The guideline-directed medical therapy, cardiac resynchronization indicated patients when the QRS complex is wide, and surgery for patients who are eligible for revascularization, mitral valve repair and or replacement, LVAD, and transplantation. Transcatheter intervention, PCI, transcatheter mitral valve edge-to-edge repair, and other transcatheter treatment like annuloplasty and valve replacement. Of course, a multidisciplinary secondary mitral regurgitation team is very important to identify which device and which procedure is indicated for this patient. Transcatheter mitral valve repair, edge-to-edge repair, the mitral clip system, the Pascal system, and the annuloplasty in the form of cardiopand also is available now. And with the recent introduction of different devices, chordal implantation, the harpoon system, and the indirect, which is the carillon system. And recently, transcatheter mitral valve replacement also is introduced, either transapical, such as Tendine system, or transfemoral, like CardioValve. This is the, on the left, you can see the stirrup guiding catheter and the clip delivery system for the mitral clip. And on the right, you can see the mitral clip at the tip of the stirrup guiding catheter. And after deployment of the device in the middle, you can appreciate the clip approximating the anterior and posterior leaflet, and on the right, the tissue ridge with the double orifice of the mitral valve after deployment of the mitral clip. We have two landmark trials for the use of mitral clip for secondary mitral regurgitation. On the left, you can see the American study, which is the COAP trial, which included 600 patients function class 2 to 4 with ejection fraction less than 40%. And when they randomized those patients to mitral clip and guideline-directed medical therapy compared to guideline-directed medical therapy alone, we can see a statistically significant reduction in the primary endpoint in terms of death or heart failure hospitalization. On the right, you will see, on the other hand, in the European study, MITRA-FR, in which they did not demonstrate benefit of mitral clip compared with guideline-directed medical therapy in around 300 patients with HFrEF. And the differentiation between the two studies, because the inclusion criteria was different. In the MITRA-FR, the severe mitral regurgitation was defined as effective regurgitation orifice area more than 20 millimeters square, regurgitation volume more than 30 milli per beat, according to the European guidelines. While in the COAPT, it was, according to the American guidelines, effective regurgitation orifice area more than 30 millimeters square, regurgitation volume more than 45 milli per beat. The volumes were higher in MITRA-FR compared with COAPT, and average 135 compared with 100 in co-op trial. So in mitral FR, it was a proportioned mitral regurgitation, which responded adequately to guideline-directed medical therapy. That with decreased volumes, this was associated with the mitral regurgitation reduction, while in co-op trial, disproportioned mitral regurgitation, not much higher volumes in which tackling of the mitral valve is needed to correct the functional mitral regurgitation. The guideline-directed medical therapy in co-op was very strict compared with the mitral FR, and the complications rate was higher in co-op trial compared with mitral FR, and the residual mitral regurgitation was much less in co-op compared with mitral FR. Recently, we have transcatheter mitral valve replacement devices available now, and the difference in the design of these valves according to the anchoring design, because compared with the aortic valve TAVI, in which calcification helps in anchoring of the valve, here in the mitral there is no calcification, and the annular diameter is dynamic. So different designs for proper anchoring is important. So many designs and many valves are available now, such as the CardioQ, such as the Tendine, which is commonly used, but it's used transapical, and transeptal, the cardio valve, and Sapien M3. So this is different types of mitral valve prosthesis to be used, to be implanted percutaneously, Evoco prosthesis, Intrepid, Tendine, as well as cardio valve. The heart team approach is very important, which is needed, should involve the heart failure specialist, the valve surgeon, the electrophysiologist, the valve imaging specialist, and the valve intervention specialist. And the guidelines recommended that percutaneous edge-to-edge repair should be considered in carefully selected patients with secondary mitral regurgitation, not eligible for revascularization, who are symptomatic despite optimal medical treatment, and who fulfill criteria for achieving a reduction in heart failure hospitalization. This is class 2A recommendation. Class 2B, if patients are not fulfilling criteria, not fulfilling the co-op criteria, in which the end-storic diameter less than 70 millimeter, pulmonary pressure less than 70 millimeter mercury, so it's class 2B in such situations. And the interesting therapeutic algorithm for management of functional mitral regurgitation, that heart team approach is class 1A recommendation. If the patient is candidate for revascularization, low surgical risk, so cappage and mitral valve surgery is recommended, which is class 2A. And if the patient is a high surgical risk, so PCI is class 2B recommendation. In patients who are not candidate for CRT, which can correct the secondary mitral regurgitation, and still symptomatic despite the use of optimal medical treatment, heart team approach is highly recommended, and the percutaneous edge-to-edge repair is considered a class 2A recommendation. Consider surgery in flow risk, which is class 2B recommendation, and class 2B in patients who are not fulfilling the criteria as mentioned before. What about tricuspid regurgitation? The tricuspid valve is challenging, the forgotten valve, and secondary tricuspid regurgitation is common, and also associated with increased hospitalization due to right side heart failure, increased mortality. And this slide shows on the left an analysis of 5,000 patients have different grades of tricuspid regurgitation, and look for the survival. The survival was much lower in patients who have severe tricuspid regurgitation compared with moderate, mild tricuspid regurgitation. And on the right, another study in the presence of tricuspid regurgitation more than grade 2. Also, the mortality rate is high compared with TR less than grade 2. And the different phases of tricuspid regurgitation starts with the mild tricuspid regurgitation, which does not necessitate intervention, just the serial echo follow-up. But with progression of TR and right side heart failure, RV dysfunction, pulmonary hypertension, we need an intervention to correct the secondary tricuspid regurgitation. So the heart team decision making is very important, and the patient risk stratification should be done, including demographics like age, gender, clinical symptoms, NIA function class, comorbidities which are common in those patients due to liver dysfunction, renal dysfunction, COPD and stroke, cardiac disease, combined left side disease or not, because TR usually secondary to left side heart disease, surgical characteristics like isolated tricuspid regurgitation or combined tricuspid regurgitation. Then cardiac pathological remodeling, which is usually happens when the severe TR lead to dilated ventricle, RV remodeling, and we have to look for the annular size, tricuspid valve morphology, the remodeling, and the pulmonary artery systolic pressure. So now we have different therapeutic modalities for tackling the tricuspid valve. Either surgical approach, and this includes suture annuloplasty, ring annuloplasty, coaptation enhancement, replacement, leaflet augmentation. And on the right, you can appreciate the wide landscape available now for transcatheter tricuspid valve, either repair by different devices like Pascal, mitral clip, cardiopand, or tricuspid valve implantation replacement. So the suture annuloplasty and ring annuloplasty, which are usually performed in step 1 or grade 1 tricuspid regurgitation, which is usually not associated with the tethering of the leaflets. It's only due to annular dilatation. So suture annuloplasty or better ring annuloplasty, which decrease the recurrence of TR with over time. When the tricuspid regurgitation progressed due to tethering of the leaflets and widening of the tricuspid annulus, lack of coaptation, we need the coaptation devices, which can be used to correct the type 2 secondary tricuspid regurgitation. With advanced stage of TR due to RV remodeling, dilated ventricle, impaired right ventricular function, we need the transcatheter tricuspid valve replacement, which are available now, orthotopic or heterotopic cable valve implant. And we have the evidence from small studies using these devices, cardiopand TRI repair study for using the tricuspid valve repair. And if we look for the decrease in the annular diameter, you can appreciate the significant reduction in tricuspid regurgitation severity. For example, at the baseline, 36% have torrential tricuspid regurgitation, which decreased after 2 years to significantly to 9% only. And some clinical improvement evidenced by improvement in the NIA function class, decreasing the edema grades, as well as improvement in the 6-minute walk distance and improvement in quality of life by Kansas City Cardiomyopathy Questionnaire. Another study, which is single-arm, multi-center study, which is TriLuminate study for TriClip to evaluate the safety and efficacy in patients with symptomatic moderate or greater tricuspid regurgitation. The baseline characteristics identify those patients who have a high Euroscore, high-risk surgical patients, 8.6, and high levels of NT-proBNP, pulmonary artery pressure, the mean was 38 millimeter mercury. And also this device was associated with significant reduction in tricuspid regurgitation severity, and 87% showed at least 1 grade improvement in tricuspid regurgitation. And after 1 year, a significant reduction in tricuspid regurgitation severity. And not only that, but also a favorable effect on RV reverse remodeling, as evidenced by decreased right ventricular end-diastolic diameter, as well as right atrial volume and increase in TAPS. All-cause mortality significantly decreased, 18.7%, and this is compared with 50% in estimated mortality under standard of care therapy. So this device also decreased mortality, and the safety was proved with the low incidence of complications like stroke, different arrhythmias, etc. And this slide summarizes the therapeutic algorithm for management of secondary TR in symptomatic patients and different approaches, tricuspid valve repair, tricuspid valve implantation when indicated. So according to the etiology, if we have primary TR due to prolapse, mitral clip can be used. Rheumatic etiology, transcatheter tricuspid valve replacement, lead induced with extreme dilatation of the annulus, transcatheter tricuspid valve replacement, or coaptation if there is no extensive annular dilatation. For secondary TR, phase 1 annuloplasty or ring annuloplasty is better than suture annuloplasty. Phase 2 coaptation, combined approach with the use of coaptation devices. And the phase 3 transcatheter tricuspid valve replacement is highly indicated, and in patients with end-stage heart failure, medical treatment or transcatheter tricuspid valve replacement can be done. And this is a new slide last year from the EU Intervention Journal showing the different modes of devices which can be used to tackle the tricuspid valve, either through repair or through replacement. What about aortic valve? We know that heart failure is a common cause due to aortic stenosis, especially in elderly. And for decades, we know that the standard of care and the gold standard of mode of therapy for those patients is surgical aortic valve replacement. However, in the last few years, we have the evidence that TAVI can be done in patients, not only for high surgical risk patients, but also in intermediate and low surgical risk patients. And this interesting slide shows when to consider surgery and when to consider TAVI. For example, for the age of 65, low surgical risk, low frailty, valve morphology, and femoral access are not suitable for TAVI. Concomitant valve disease like severe aortic regurg or severe mitral regurgitation, significant coronary artery disease, those patients are ideal to be considered for surgery. On the other hand, TAVI is highly recommended in elderly, 85 years or more, high prohibitive surgical risk, Euroscore more than 8%, and the severe frailty, valve morphology, and transfemoral approach are in favor to use TAVI. And the concomitant valve disease is not significant, as well as the coronary artery disease, one or two vessel disease, and other indications. These indications are considered to favor for TAVI compared with surgical aortic valve replacement. And we have many meta-analyses compared the TAVI versus surgery. And in this meta-analysis, that TAVI probably improves all-cause mortality or disabling stroke up to 2 years, may slightly reduce major bleeding, new onset atrial fibrillation, and acute kidney injury. I mean, just 1 minute. Okay. And probably increased TIAs, major vascular complications, permanent pacemaker implantation, re-intervention, and paravalvular leak. And this slide summarizes these meta-analysis that TAVI is associated with lower incidence of AKI, new onset atrial fibrillation, and on the other hand, it's associated with major vascular complications and the need for a permanent pacemaker. And we have different devices which are available, either self-expanding or balloon expandable. So again, Evolute Pro, Sapien 3 Ultra, Lotus, different designs which can be considered after doing CT angiography before the procedure to decide which valve to be used for those patients. And the guidelines recommendation for TAVI or surgical aortic valve replacements, class 1B recommendation in patients with heart failure and severe high-grade aortic stenosis to reduce mortality and improve symptoms. Heart team approach is important to define which procedure TAVI or surgery is recommended according to the surgical risk. And this slide summarizes the recent HFA 2021 EC guidelines for management of patients with severe aortic stenosis. And we can see that TAVI is considered in elderly patients with high surgical risk compared with surgical aortic valve replacement. And in patients with low flow, low grade aortic stenosis, also doing dobutamine echo to assess the flow reserve, and then heart team approach to decide for surgery or for TAVI. And this last slide, that the conventional surgical approach for patients who have severe aortic stenosis, moderate mitral regurgitation, and severe TR is to do aortic valve replacement and mitral valve repair, tricuspid valve ring. On the other hand, you can do TAVI and then reassess secondary mitral regurgitation severity if the patient is indicated to mitral clip or not, followed by reassessment of the TR severity to do transcatheter tricuspid valve procedure, repair, or implantation. So the conclusion, ladies and gentlemen, the secondary mitral regurgitation is a common consequence of LV remodeling and is associated with adverse prognosis. Transcatheter edge-to-edge repair should be considered in carefully selected patients who remain symptomatic despite guideline-directed medical therapy, including CRT. Transcatheter treatment of severe symptomatic TR in inoperable patients is class 2B recommendation. Transcatheter mitral and tricuspid replacements are now expanding. TAVI has now emerged as an established treatment option in patients with symptomatic aortic stenosis. Thank you for your attention.
Thank you very much.